Hello, everyone. My name is Irem Sengül Orgut, and I'm an assistant professor of operations management at the University of Alabama. I'd like to talk about our paper entitled Optimal Policies for Nutrition Administration to Very Low Birth Weight Infants that was recently published in Decision Sciences Journal. This is joint work with Dr. Gustav Falseglia, who is a physician of neonatology at Lurie Children's Hospital in Chicago, and Dr. Karen Smilowitz, who is a professor at Northwestern University. In this study, we focus on premature infants of very low birth weight, which means they were born with a birth weight of less than 1,500 grams. Studies show that very low birth weight infants are at risk of postnatal growth restriction, which has short and long-term effects on health and neurodevelopmental outcomes in children. For this reason, it is important to understand how nutrition is associated with growth and how these associations may vary across infants based on infant characteristics and comorbidities. We asked 3 research questions. 1, can we identify naturally existing subgroups or clusters in a cohort of very low birth weight infants using infant characteristics and comorbidities? And how does clustering based on basic and easy to obtain data compare with one that uses complex diagnostic data for infants? For this research question, we use clustering, which is an unsupervised technique, to identify naturally existing subgroups within a cohort of very low birth weight infants. Also, we compare a simple clustering scheme that uses easily obtained information about infants, which are in this case only birth weight and infant sex, with one that uses infants' treatments and diagnoses, which may not be available until 6 weeks of life. The second question is, are there any differences between infant subgroups based on the association between nutrition and growth? For this one, we use multi-level models to find differences between the identified subgroups in terms of how they respond to nutrition, and we highlight which factors affect growth the most. Lastly, we ask, can interpretable and easy-to-use medical decision support tools provide accurate classifications of infants to help clinicians make personalized nutrition delivery decisions? So physicians make nutrition decisions for each infant very quickly when they are rounding, and they do not have access to resources to run complex models. So we must provide tools that they can implement on the go. So to answer this question, we used mixed integer programming models to develop medical scoring systems for clustering infants based on their characteristics, treatments, and diagnoses, taking into account the trade-off between model accuracy and sparsity. We used data from 115 very low birth weight infants born between 2011 to 2014 and admitted to Lurie Children's Hospital. So let's look at our key findings. For the first question, where we ask, are there naturally existing subgroups? The answer is yes. We found that although cluster populations varied slightly among clustering schemes, cluster 1 generally consisted of smaller, sicker infants with larger variations in growth. In contrast, cluster 2 generally consisted of larger, healthier infants with smaller variations in growth. Also, clusters based on early limited data involving only birth weight and sex were similar to clusters obtained using complex diagnostic and treatment information. Second question asked, are there differences between the clusters? We found that first, modeling performed using clustering schemes was a better fit than models performed without clustering. Further, each cluster responded differently to calories and protein. While we saw that cluster 1 was more responsive to protein, cluster 2 was responsive to both protein and calories. For the last question, we were able to develop optimal scoring systems, such as the one shown here, that clinicians can use to quickly determine the cluster of a given infant. Clinicians can use these policies during their rounds, as they do not require any equipment or software and can be implemented by simply checking a few conditions and adding a few numbers. This would help clinicians categorize infants as higher or lower risk of being in a healthy or sicker risk group and target nutrition regimens accordingly. This concludes our video. This was just a quick overview. Please see our paper for details, and thank you for listening.